Hi, my name is Marybeth+Trapani Hanasewych, and I am a speech-language pathologist. I work at the Children's Institute, which is a freestanding rehabilitation facility in Pittsburgh. It's about 2 miles down the road from Children's Hospital. So we're two different facilities. We have both an outpatient and inpatient facility. I guess, can you hear me? Is this good? Okay. Is everyone from out of town? Who's from outside of Pittsburgh? How's that? Okay, that helps a lot. Because what I can share with you, I'll share with you what we do at the Institute and some of the things that we look at, but I can also share with you is kind of what you might want to look for in a program in your facility. There is now actually an international consortium on feeding disorders, and they've collated the collection of sites and places where you can receive treatment. So let me just start with this. I've been doing feeding at the Institute probably for the past 20 years, and I love it because it keeps changing. As technology and as we learn about new medical advances and new diseases, we have to modify. And the team really started with a much smaller group, and it's just continued to add people because the issue has become so complex. So the kinds of kids that benefit from these kind of programs would be those with anatomical or physiological conditions, those who just might avoid eating as a learned behavior, those who can't be weaned from a tube feeding, and those who can't progress to more difficult food textures. We see many of those. And then those children with just a plain old food aversion or oral aversion that can start very, very young. I have seen it at, 4 weeks, 8 weeks, 4 months. It's pretty significant. The kinds of kids that I think many of your children would fall into is we tend to see these kids fall into 4 groups. And one of the groups are these children that are medically fragile, who may have things like failure to thrive or GI issues or bronchopulmonary dysplasia. We see a number of transplants because Pittsburgh is a transplant center, cardiac issues, pulmonary issues. So we've had the opportunity, and I think that's one of the things that really helps if you have a complex issue, is to go to a center like that because they've had the opportunity to see many, many, many children like that. The other group that we see are those children that are moderately to severely involved, meaning that they have pretty significant developmental delays or cerebral palsy that's very involved. Sometimes they have neurodevelopmental or genetic issues. Things like mitochondrial disease has been one of those challenging ones. The other group of children that we see are those children on the spectrum. And I have definitely seen children with lung issues who also have sensory issues. This is sensory integration dysfunction. Not all children with autism have sensory issues, but many children who have medical issues do have sensory issues. And some of that has to do with their experiences that they've had. And if they've had a lot of negative experiences around the head and neck and mouth, many children who have been in NICUs and have had to been intubated a lot or have had a lot of OG feedings, oral gastro tube feedings, it's very, very negative around the head and neck and face. The other group of children that we see are those children with psychosocial disorders. And those can really range from a very chaotic family that lives in public housing and 17 people are living in a 2-bedroom apartment, there is no crib, to the family that lives in a very metropolitan kind of area. Dad works, mom stays at home with the kids, and it has a lot to do with how the families react to the children. So the disciplines that are generally involved in an evaluation are a physician, a speech pathologist, an occupational therapist, a dietitian, and a nutritionist. you've had to fill out a pretty extensive case history form, and you can go online and see many of them. So the whole experience is, and have any of you had feeding evals with a team? Okay. The experience may be different, but our experience is the physician really does an examination of the patient, and then they come into a room with all of these people there. And we ask them some additional questions while the occupational therapist really engages them in some sensory activities and some vestibular movement activities. And that usually takes us about, and we ask the family to bring in their food, and we want to see how they eat typically, what they typically will eat. And then we also want them to bring some foods that they would like them to try, but they're not too keen on. And we'll observe that. That whole part takes us about 45 minutes or so. Then the team steps out of the room for a few minutes to kind of put our heads together. Then we come back in and we give you the results of the evaluation and the recommendations where we think we ought to go from there with your child. And we're going to take a break, and you can ask him a question while I reload that. How's that?
Thank you. So that's a great question. So the question is, it's relating to the confusion between what symptoms are due to the underlying psychological or psychiatric condition, such as depression or anxiety, and coping with stress, versus what symptoms are due to the disease itself. And can treating depression, anxiety, or how to cope with stress lead to an underestimation of how bad the disease is? Am I correct? So actually, that's the first time I've actually heard it framed in that way, which is really interesting. And my answer is no, from patient experience. And reason being is that if you treat the depression, anxiety, and ways of coping with stress in someone who has a chronic disease, you do have potentially other markers of disease activity index that can lead to accurate physician assessment for how bad the disease is. There's less invasive ones than, for example, a scope. In GI, we do have lab markers that can be helpful, as well as growth, which is excellent in pediatrics. If someone has no symptoms, but I've seen patients who haven't gained weight for previous 3 years, even though they think they're okay or they've been treated for depression and their symptoms, somatic symptoms, so to speak, are not there, and I see that they haven't gained weight in 3 years and they're 15 and haven't gone through puberty yet, then I totally table their symptoms down and say, you know what, there's more evidence that something else is going on in you than your symptoms say. So does that help answer your question?
Yeah. And the other question I had was, with adults with conditions like COPD, they'll undergo pulmonary therapy and to increase their capacity to exercise and to be more comfortable. But with children, those aren't offered to our children to go through those types of programs. And can we expect that to change over time, that children will receive the same type of treatment that adults receive as far as lung conditions, but also with pain management? Typically more adults will be treated with pain compared to children being treated with pain because they're perceived as to not experience those things the same as adults.
Excellent question. I'm sorry.
Well, I was just I think there's actually, the problem is that the pediatrics have so many life stages, and it's a lot more difficult to establish what the standards of care should be for the children. I don't think that it's being ignored. I think it's still being addressed and developed for the different life stages. I would expect to see it, and I would expect to see it coming out of the research network in the next few years, because the preliminary research is being done. It's just going to take a while to figure out the accepted standards for those therapies.
Exactly. And I completely agree. There's a select few centers, and the Children's Institute is one, and Dr. Trapani will actually be able to elaborate on that probably. But there's a few centers out there which focus on people who have chronic pain conditions, and they have inpatient therapies which involve physician, psychologist, social worker, as well as a feeding therapist to help them deal and work through that too. Mm-hmm. So they need to grow. So I'll let you get back.
Okay. These are usually the most common areas of concern that we see with some of the children. And I can let you read those. I don't have to read those to you. Because I want to try to get through this pretty quick. I'm going to skip some things so that you can ask your questions. Some of the red flags that we see for potential difficulty, sometimes we have families who are hesitant to come in for an eval because they think, oh, it's not too bad. But I can tell you the rule of thumb for treatment is the sooner the better, because I feel that we are able to prevent many issues down the road if we can treat them much earlier. So if they're seeing persistent reflux, failure to grow over 2 to 3 months, their weight and height are below the 5th percentile, they might be on long-term seizure or reflux meds. If you see excessive drooling, mechanical feeding difficulties, metabolic or progressive disorders, suspected caregiver neglect or depression, or a dysfunctional home environment. All of those things would be pretty big red flags. I talked to you a little bit about the case history forms that we're doing. We also have a team of a smaller team for kids under a year. It's a clinic. It's the physician, the speech pathologist, and the dietitian that are looking at them. We had to grow that out of the need from the community that the pediatricians were saying, you need to see this baby right away. And that way we were able to get the babies in a little bit quicker. And again, we're asking them those questions and then observing what's happening. The things that will come out of a feeding eval might be treatment from a single discipline for outpatient or multidisciplines, parent education, maybe some adaptive equipment, referral to or incorporation of other team members, referring them to ENT or GI, social work, or refer them for an inpatient admission. Just going to skip over this. Sometimes we see children who are pretty far away. We draw from, I would say, from the Erie area down into Morgantown, all the way east to Harrisburg, Du Bois, that kind of area. And those kids can't come in every week for treatment, and they have EI teams in their area. So what we try to do is see them on a monthly basis and collaborate with their EI teams, because the EI teams may not have seen that particular kind of child, and we're helping to develop, I think, better teams out there with more skill and more precise treatment that they're doing. Okay, I told you about that. Some of the goals that we'll ask the family, that's one of our first questions. What are your goals? You want to increase variety, you want to increase volume, self-feeding, improving mealtime structure. The one thing that we know about behavior is that every behavior has a function. And many of the children that I've seen with lung disease have a number of behaviors around the whole feeding issue. And I think sometimes the psychologist really helps to remind us that every behavior has a function. They just didn't get up in the morning and decide, no, they're not going to eat anything. It's because they couldn't breathe, they don't feel comfortable, they have all that phlegm. There's usually a reason for that, and how to deal with that is what we kind of look at. And there's some additional goals. We definitely use all of these kind of supportive feeding strategies to help meet the needs of the children. I think the thing that you should look for in a feeding program is to always look for that they're looking at the whole child, that there isn't one discipline just looking at one thing. That's what I really like about our team, is that our team really looks at the whole child. There are programs in the country that are very focused on the psychological aspects of feeding and are led by psychologists. Our team's not led that way. It's really a team focused in a medical model, which has the support of psychology, OT, speech, and things like that. I talked a little bit about the intervention options, outpatient treatment. We have an inpatient program that is about 4 to 6 weeks in length. We do pull in patients from all over the country for the inpatient program, and I would refer you to the website for additional information if you're interested in that. We bring those children in when they're really ready for a big push. And many times they are in outpatient, come to inpatient, and go back to outpatient. This is a typical inpatient day. It's packed. There's not a lot of downtime for them. This is some of our outcomes from our feeding program. the number of days. We had 58 patients. We had 37 with tubes. And then there's the breakdown of their diagnoses to the right. And these are some of our outcomes, those that were able to increase in textures and oral intakes and increase in variety of oral intakes. One of the problems with comparing feeding programs and looking at outcomes is there is no national standard of outcome. So in this consortium, that is what the feeding programs are trying to do, so that parents could actually compare and find the program that's right for their child. And here's some other data as far as decreasing in tube feeding requirements, no change in them, and increasing. And sometimes I'm always told to say, well, oh my goodness, they increased in tube feeding, we failed. Not at all. These are some of the kids that are on TPN that we wanted them to be able to take something in their gut, and they're able to take a G-tube feed and not the TPN. So that really was a positive outcome for us. These are some other data requirements that you can look at. One of the other flyers I have are our modified barium swallow studies. I think that in the next 5 years, you're going to see a lot of literature about there is a lot of literature out there now, but we're really looking at the coordination of respiration and swallowing, breathing and swallowing. There's a definite pattern to breathing and swallowing in that you inhale, you exhale a little bit, you swallow, and you exhale more. And what we're finding is that many of the children, not many of them, we don't know yet. We've probably run about 8 kids through this. But I'll let you all try this. What I want you to do, if you have something to drink there, what I want you to do is try to blow all your air out and put something in your mouth. Try to blow all your air out and swallow. It's usually a little harder because you have very low tidal volume in there. Now what I'd like you to do is put the water in your mouth, take a big breath, and swallow what's in there. Is it easier? Think about, I figured this really worked when I tried to take my calcium pills. Those are big, giant pills that they go down much easier. And part of it is just the physiology and the anatomy that when the lungs are inflated, they get off the esophagus. And therefore, it allows the food to just go down a whole lot easier. So I think that's an area that we're looking at the Children's Institute, and I think you'll see more of that across the country. The picture here is a C-arm. Have any of your children had to have swallow studies? So let me tell you about that. This is a C-arm, and I would ask your facility that you're going to. Many times they put the children on an X-ray table that has a foot plate attached to it, and then they put the chair on the foot plate, and then they strap them to the table. And, you know, that's not very conducive to really eating well. And so what we've been able to do at the Institute is we use a C-arm. They use it in the ORs and things like that. It has a little bit lower radiation, and we hook it to a K swallowing center, which allows us to collect all the data that comes off the C-arm and then analyze it with more specificity. We can use the C-arm on a high chair. We can use it on a wheelchair. We can use it with a vent. They can sit in the seating that they're in. And I would encourage you to try to ask your facilities if they could manage that, because it's just, I think, a much truer study for the kids because they're more comfortable. One of the other things I wanted to show, I don't know if you have any children that are on continuous G-tube feedings or TPN needs. There are these backpacks that we have developed for kids so that they can just carry all their food with them instead of carrying the pole with you. So I stuck that picture in. We also do some electrical stimulation for swallowing. I think that there's a lot of evidence out there that's very controversial. Does it help? Does it not help? I think it's a sensory component to it, and we've been most successful using it with children who are drooling, actually. It's that they don't really get that. It's really, you're not getting a muscle contraction, you're just getting the sensory input, and it's enough sensory input in combination with maybe some Botox to the salivary glands that we've been able to get kids off of all their meds using electrical stim. So I think the jury's still out on that. That's why I love this. There's always something new. This is how you would refer. And if you have any questions, I think we'll take questions. Okay, did I leave time? Yes, okay. Any questions? Sure.
I think one of the most common questions that come up on Facebook and in discussions with parents is when you have a child with reading problems and with a G-tube, how do you avoid feeding food aversions in the first place? I mean, are there any tricks of the trade, like if somebody is G-tube fed, that you would recommend to keep them from getting oral aversions and stop eating?
We believe in a very positive approach. So if you mean to avoid the G-tube feeding at all?
No, it's just like the kids, some of our kids get G-tube fed at night and for supplement, and then they stop eating during the day because they
Right.
feel full, and then eventually they'll get food aversion. So there's a lot of questions. What can we do to keep them from ever getting the feeding disorders in the first place?
Well, one of the strategies that we tend to use is we try to move all of their feedings to the day, because that's when your body is used to eating, so that you eat during the day and you sleep at night. Because it's very hard then to kind of shift that to, I eat all night, I'm not hungry all day, I don't eat all day. So that's one of the strategies we use. And sometimes there's lots of advantages to that, because if you put them on a backpack, if they're on a continuous feed, then they're mobile. They can go all over the place, versus if they're in their bed, sometimes they get tangled up in the tubing and then the tubing leaks and things like that. So that helps. We always believe in the positive. Just if what they really love is Cheetos, then have at it. Eat as many Cheetos as you want. Our dietitian will tell you a calorie is a calorie is a calorie. So we really believe in a more positive, a positive approach, even if it's only ice cream. Yeah.
Do you have a list of programs around the country in Canada or somewhere that you would recommend? Because both my children went through feeding therapy, and it was horrendous disaster for both of them. For example, the first one, I had the therapist tell me that he was behavioral and that I should turn his high chair and make him face the wall as a punishment. I mean, you can't imagine. So I stopped that and kind of did it on my own. But so looking for a program that, do you have recommendations or accreditations that we should look for, or a methodology, or?
I think looking at their outcomes would be one of the first things that you want to look at, and they should usually be out on their site somewhere. I think as far as the list of which ones to go to, I mean, I think that's why it's America. You know, you can't say, you know, this is the one. You have to, you know, kind of read a lot about it and find out which one fits you best. But I would recommend looking at their outcomes. The consortium soon will, and when I get that information, the consortium has a list. I mean, it's a humongous list of places that do feeding. That list, I've asked them to, can we distribute that list or put it out somewhere so that people could find it? And they're meeting to decide what they're going to do. So if they decide to put it out, I will let you guys know.
For us, with our daughter, she's 2.5. So the problem is kind of a combination of feeding and stress, because she throws up. So a body under stress trying to eat. So she's become fussy, and if we tube feed her, she'll throw that up. If we oral feed her, depending on if she's stressed, she'll throw that up. So, like, what kind of an approach can you take with a body under stress that's trying to eat and keep some calories?
Take it away. That's a tough one.
Yeah, I agree. I have a question for your question first. So what triggers, what does she get stressed about? The act of eating itself, or is it something other? Got it. Got it.
but she'll just throw up. So sometimes it could be she'll get a gag pill, that'll cause it. Sometimes it's nothing at all. Before it was more common that she would just be eating, throw it all up, and then eat it.
Got it.
She can start coughing, and we know what's going to happen.
We can start.
Calm it up during trying a hot dog, and she'll ask for more hot dog within seconds of doing that. So we do that.
So
That had no effect whatsoever. Just I'm really hungry now. So
you guys are describing, and I'm glad you chimed in saying I couldn't hear if your child does the same exact thing. You guys got, yeah.
What helped us the most was actually backing away from the medical field, saying, you know what, we're going to do it our way for a little while, see how it does.
Right.
We took out his G-tube. We started feeding him by mouth. He started gaining weight, stopped vomiting. Now he's a perfectly healthy
We
7-year-old.
find that happens with interstitial lung disease, I think. I think the theory that, by talking to other parents is, it seems like you have these kids who get pushed, like cystic fibrosis kids, to eat, and these ones do the opposite. That makes them lose, and puke. Like, the more we fed her when she was little, the more she puked like 15 times a day.
Right.
And when we did back off a little bit, it got better. But now she'll have, it's a
Oh, go ahead. After you, please.
tender line with her.
I was just going to say, one of the things that I tell families is sometimes you have to go slow to go fast, that you really have to take a step back and go to the place where you're successful and move from there. And sometimes that's really hard to do because they're throwing up. And I've found kids like that around the age of 4 seem, for some reason, it just, as long as they're getting the food orally, it stays down. Or if they use blenderized tube feedings, it works better than the formulas.
her corner, or she seemed to, she has a G-tube, and so she was fed primarily through the evenings. Like when she fell asleep, we would try to syringe feed her, and we noticed then during the day she would have an appetite. She seemed to, want to eat a lot more, and so there was this
good.
bonus of feeding her at night, and she would sleep really, really well, and also feed during the day. So she just, it's a combination of, I'm really hungry,
Right.
and, oops, I threw up, and I'm still hungry.
I just always say never.
Yeah.
Like one thing that works for one person may not work for the next.
Can a child survive on Doritos?
Yep.
I just want to say what you
They
said.
need the fluid.
I think is true, because mine threw up like for the first 2 years of his life, and it was the lung issues. And I think the gag reflex, and at some point when they're like 2.5, around 3, he all of a sudden just stopped. And it wasn't, he has GI issues, but it wasn't the GI issues, it was just that gag thing. And so they looked at everything else, something else is wrong with him, but it wasn't. It was the lung stuff, it was the coughing and the gagging, and all of a sudden he just stopped. So.
I think the other thing, just to touch upon, you guys really, so the situation you guys are describing is very common, I will say. So, it's complex in terms of causing. It's likely a combination of what happened early on in terms of tubes, right? Which can contribute to the hyperactive gag reflex. Plus, as we saw, the effects of stress affecting how things move, plus the effects of working oneself up. Right? And the most important thing, I think, of all of them is when you get into that 1 to 4 age group, who's in control? Who wants to be in control? Yeah, they do. So it's with everything. I mean, we're seeing it with our 1-year-old son right now. He wants to hold the spoon. He wants to hold the bottle. I touch it and I get in trouble. Okay? So the same thing happens. If you push something and they feel like they're out of control, just like you guys did, and let them do what they want to do, then things are going to actually improve much better than forcing. So I think you guys are on a good page with what you guys did, and I think it's smart because then it helps them develop their own tolerance and what they want over time. And I really like the comment about you can live on Doritos. You can live as long as you're getting stuff in the mouth. It's a good sign because things will get better over time and things will diversify over time, but it takes one thing to start.
Right. one thing I would add is, I don't know if any of you know about this training, Love and Logic. It's actually out of Colorado, and I would refer you to look at that because it's a lot about choices and having the kids make the choices, that you're in control of the choices. Like, do you want Doritos or Cheetos? You still controlled the choices, but they feel like they're getting to make the choice. So I would refer you to that to look at.
I wanted to share the same thing, and I post this on the Facebook page all the time, but my Maddie was tube-fed from birth, and we had the summer of puke in 2008, and we took some control of ourselves in reducing her calories, but she did start eating on her own Doritos. I ketchup. I didn't even care, frosting. And then we did meet up with the team, and it didn't take too much, but the team really helped us we put the food out, and fruits and vegetables are always on the menu, and this is what's for dinner. But she's my best eater now. She gained 16 pounds this year. She is awesome, and she did not put anything in her mouth voluntarily before 3 years of age. And I mean, if you went at her, she would throw up. So it's hurtful for us because this is how we take care of our babies. But if you work very slowly at it, if you told me my child would eat sushi, I would have just not believed you. If someone could bottle a day in our life now and have shown it to me 5 years ago, it would have really helped tremendously. So I brought her along so you could all see her eat. She's a messy, messy eater, and that's mine. So.
I think a lot of us have kids that are under 5, and that's a really hard age to reduce stress cognitively. Do you have any techniques that we can use while we're in the million of medical testing things that they have to go through, or like any techniques that we can use for them to reduce stress?
So I was anticipating that question, actually, and the question was techniques to reduce stress in someone who is under the age of 5, and I did a lot of searching, and at this point the main ones are distraction, right? But as we all know, when we get older, distraction isn't the best way to deal with stress, right? It's a bad way of coping. So we get into the realm with that age group where I think the help of an expert in that field is ideal. A counselor, or they can either be a social worker, a psychologist, any other form of licensed therapist, because if they're pediatric specific, it gets to be very individualized in terms of how to respond and how to work with that. And I think that's the really helpful way to do it. Also, Child Life. Is anybody familiar with Child Life here? They're immensely helpful for our entire team at the hospital, especially in that age group. So they're also really would be a good way to have. And I'm sorry I don't have a clean answer, but I think if I gave one, it'd be wrong. So go ahead.
I wanted to say too, with our son, he's medically complex. He has interstitial lung disease, but he also has cognitive disabilities, and we're just grateful that he is able to eat something. He's on L-Care, so it's elemental. It's basically the only thing his body will tolerate at this point. And one of the things I'm hoping is that as he grows and his lungs improve as he gets older, that his GI system will improve as well, and he'll be able to start to eat food. He wants to eat. He has structural anatomy problems with his jaw as well, micronappia and whatnot. But he chokes and gags on anything more than a puree, but then he'll have an immune system response to that food immediately. So we also have the problem of finding any food he can tolerate. So I have to kind of accept that it may be a long time before he can eat, and I expect him to have to go through a program inpatient to learn how to eat, and hopefully he'll be able to go through one of those programs. But it is heart-wrenching, as all the parents here know, and things like that. So I am grateful for those types of medical advances. And so I wanted to just say that even though he can't eat and we're working on it, I expect him to hopefully eventually get there, but it's not the most, it's a difficult situation, but it's not the worst thing.
I'd keep working at the oral skills. It doesn't get better avoiding it completely. And there's so much work that can be done before you even get to foods. And, allowing kids to do a lot of play with toys and toothbrushes and things like that are really important.
It's very difficult if you're not in a center, a healthcare center, to find to find therapists that can treat medically complex children. So you may get an assessment at a center, but then the follow-through care, there may not be people who are trained to deal with your child. In my experience, I haven't been able to find a single feeding therapist that is able to.
And where do you live?
I live in Raleigh, North Carolina. So we go to Duke, and we've gone through many therapists. We haven't been able to find someone who's able to address his needs. Most of them end up giving up, that they say they can't help.
You need the list. I know. You need the list. And I will get it to them as soon as they release it.
Anybody else?
Thank you.
Thank you.